Well, hello, everybody. My name is Garrett Schmidt. I am the managing editor for VBC Exhibit Hall, and I'd like to welcome you to today's live webinar hosted by Health Data Analytics Institute, or HDAI as we call them. And it is titled Reducing Clinician Burnout Through AI and Meaningful Data. And I'm super excited about this one because obviously anything AI is just really interesting right now, and there's a lot of great applications, and we're learning so much about it. So, and of course, clinician burnout is a real thing that a lot of you are dealing with in your own organizations, or maybe personally if you're a physician. So there should be a lot of good information here. Very excited to hear from our speakers today, who I will introduce in just a moment. A couple items of note before we get started. Everyone has joined today in listen only mode, so it's a traditional webinar format. We can't see you or hear you, so don't worry about that. But as I always say, we do want to hear from you. So we're going to have a time for some Q&A towards the end of the presentation. So if at any time during the presentation you have a question, go ahead and submit that using your control module. There's actually a space there that's for questions, which is different than the chat. So go ahead and drop your question there. We're going to get to as many as we can. If for some reason we're not able to get to yours, that's okay. Someone will reach out via email afterwards and get to you with that answer. So please don't hesitate to ask a question, even if we're wrapping up at the very end. All right. Oh, and finally, one other thing, we are recording the session today. So what's going to happen is about an hour after, roughly about an hour after the end of the presentation, you'll receive an email, and it'll have a link to the recording as well as to where you can download the slides. So you should have all that information if you want to review it or share it with colleagues, and we hope that you do. So without further ado, I'd like to very briefly introduce our speakers today. We have with us Mr. George Pace, and he is VP of Partnerships with HDAI. And we have Ms. Emily Hightower, and she's the Population Health Manager. And we also have Miranda Joseph, and he is the Director of Care Management Advisory Services, all with HDAI. So really glad to have you here, folks. Welcome.
Thank you.
Garrett, thank you so much. Appreciate it. Thank you, everyone, for making time to attend. Good morning or good afternoon, depending on where you are in the country. I am George Pace, as Garrett said, Vice President of Partnerships with HDAI. Before I say anything else, I want to apologize in advance because I don't have a fake background on behind me. This is my actual room. And through this door, there's about a 50-50 shot that one of my two dogs, or perhaps both of them, will make an appearance. They don't love to be behind a closed door, and so they may just come in to check on me. So again, apologies in advance if they do that. They don't bark, but they are curious little critters. So so that may happen or not. Really briefly about us before we jump into the topic of the day and who HDAI is. We're going to talk a little bit more later about HDAI, but in a nutshell, we are a care optimization and predictive analytics company. What that means in a nutshell is that we use large data sets, claims data, clinical data, and clinical generative AI to create predictions about individual patients that enable nurses, care managers, doctors to better care for their patients, helping them prioritize, helping them surface what might be latent or invisible risks that they couldn't otherwise see in their EHR data. I'm not going to talk about us today. We love at HDAI to talk about our data science and our models, but today's topic is not that at all. Today is the first installation of a 4-part series on how technology, specifically AI, can contribute to our achievement of the quadruple aim. As you see here, there are going to be 3 more events, I would say. 2 of them are going to be content pieces that we're going to publish on social media. So if you're interested, please follow us on LinkedIn. And then there's going to be another webinar on December 5th focused on population health and AI and the intersection of those 2 things. For today, we're going to talk, and that's by we, I don't mean me, I mean primarily Emily and Romanis, who are our 2 experts in this area, talk about provider burnout and how much of a detriment it is to healthcare today and going forward, share some of their personal experiences, which, as we hear in a second, are related but fundamentally different. Emily was very much on the front lines of direct patient care, whereas Romanis has that expertise, but also worked at more of an organizational and administrative level to manage teams of folks who care for patients. And they'll both provide their unique perspectives on these topics, and talk about specifically how we can use AI to alleviate some of the stress that we're all feeling from staff shortages and other sources of burnout. So Julie, if you wouldn't mind taking us to the next slide. So real quickly, I'm not going to belabor this. You can all read what's on this slide, but a couple of things I want to say here just by way of doing some table setting before I pass on to Emily and Romanis. Number one is that, as you can probably see, I'm old. I've been doing this for a while. And since I've been in healthcare, which is over 2 decades, I've been hearing about staff shortage and burnout. Now, when I first started out, staff shortage was spotty. It wasn't everywhere in the country. It was, in certain markets in certain regions where it's perhaps a little bit harder to recruit clinical talent. But we've been hearing about burnout for literally over 20 years. In fact, I have a personal friend whose practice is in helping alleviate clinician burnout on the one-on-one level. He works with other physicians to help them with their own clinical burnout. And he's been doing this for decades as well. However, as bad as it was pre-COVID, COVID absolutely amplified and accelerated these dynamics. And so what we're seeing today, I would argue, is reaching, if not already at a crisis point. I don't think I need to tell you all about the recent news coming out of Kaiser and then even more recent news coming out of Tenet about massive numbers of clinicians walking out, in part due to stress and burnout related issues. The numbers are concerning, right? In a recent poll, 34% of nurses nationwide indicated that they were planning on leaving their professions by year end. And of that 34%, half of them cited burnout as the primary reason for their interest in leaving. Now, the focus of the coverage, and perhaps rightfully so, has been providers, right? Doctors leaving practice to go into consulting or other professions because of the burnout and the stress, et cetera. What we think about at HDAI more so necessarily than the providers, it is the providers, but it's also the patients that they care for. Probably not surprising to anyone that when you have shortage of staff and on top of that, you put incredible stress and burnout, it's not going to bode well for outcomes and direct patient care. And that's not a criticism at all. It's just the reality that we can only handle so much. And the more that gets piled on due to shortage and stress, the harder it's going to be for folks to practice at the top of their licenses, as we like to say. And so the impact on outcomes is really more so what we want to talk about today. Alongside this press, the press about burnout and stress and all that stuff, I'm sure you've all seen a lot of reporting on AI. Everybody is talking about AI, what we can do with AI, all kinds of, every day I see new announcements of new vendors getting into AI as part of their solution set or their entire solution set. And while that's certainly very interesting to us and something we watch closely, what's more interesting to us is not so much the AI in itself, it's how can it make a difference? Because as I think Romanis will speak to a little bit later, there's absolutely a risk that when we keep piling on more data, more alerts, more tools, more solutions, eventually you reach a point of overload, and it's simply too much for you to manage and too much for you to keep track of, and you end up not using any of it to its maximum extent. And so the question we want to pose today is, how can we thoughtfully and intentionally use AI and embed it and incorporate it into the clinician's natural workflow to elevate patient care and alleviate some of this burnout and stress that we're seeing industry-wide. And so with that said, before I pass to Emily and Romanis, I'm going to pose a quick polling question. Garrett, if you would please put that up on the screen, and if you'd all take a moment to think through this and respond. So have you witnessed firsthand negative impact to patient care due to burnout or burnout-induced staffing shortages?
Okay, I'm pulling this up on the screen, so you all should see this. And go ahead and take a second to vote. This is a select one only. So pretty straightforward. Yes, no, not applicable. And we still have a lot of responses coming in, so we're going to give it a few more seconds here. And then we'll move along to the next one. So I'm going to Let's see here. Give it about 10 more seconds. We still have responses flooding in. So, all right, I'm going to shut it down at about 5, 4, 3. It's a long 5 seconds. 2 and 1. Here we go. I'm closing it down and I'm going to share the results.
Yeah, yeah. Sadly, not surprising to see numbers this high, indicating that they have seen, real impact on their organizations. And not that it's any comfort, but we're seeing this and hearing this from all of our clients and all the organizations we speak with. And so again, hopefully to sort of pivot to a positive note, we can talk today about solutions and what kinds of technology can make this better. So,
Okay,
Jared, I'm still seeing the poll results.
yeah, let me go ahead and pull that down.
Oh, okay.
And then we
Yeah,
should be
awesome.
back to the slide. Oops, looks like we lost the slides.
Okay. All right. So while the slides come back up, I'm going to pass to Emily
There we
and
go.
Romanis. Both of you, great to see you as always, and thanks for joining. And as all of you will quickly recognize, you're going to hear much more from the smarter people in the room than you will from me. So I'm gonna shut up now and pass to Emily and Romanis.
Okay, thank you, George. Can you hear me okay?
Yeah.
All right, we are so excited to be here with all of you. Thank you, Garrett, for having us. Thank you to everyone who logged on. We're excited to talk about something that we feel so passionately about. I will let Romanis make his own introduction, but we do work very closely together at HDAI. I am a population health manager here on the Care Management Advisory Services team. Prior to coming here, I worked as a manager of provider engagement at Lumeris and focused heavily on population health. My roots, my background are bedside nursing though, and nursing education. So I began in the emergency department of Cincinnati Children's Hospital in 2014, about 7 years ago. I was first a PCA, then I moved into my new grad role a year later. And PCA is a patient care assistant. I just say it to make note that everything we talk about today goes across all spectrums of healthcare. So after about 3 years in the emergency department, I transitioned to the Cancer Blood Disease Institute, also at Cincinnati Children's, slightly different schedule. It was a clinic. Some of you may be able to relate to this if you are in the field, but prior to making that transition, I really was already feeling the effects of burnout and caregiver fatigue. That was very early on in my career, so that's impactful. We were often short-staffed, we had high patient volumes. I was really feeling that stress and that burden, both emotionally and physically. And all of that was before the COVID pandemic. And then COVID happened. I feel like, as George mentioned, it really just highlighted and exacerbated the already existing problem that we could no longer band-aid, but we had to figure out a long-term solution to. In fact, I remember that during COVID, the system, and this probably stands true all throughout the country, but we weren't sure what to expect with patient volume, even in the pediatric space. So anybody who had recently left the emergency room was mandated to go back and train in order to be available if we had staffing shortages and high patient volume. So fast forward, all of this ultimately led to me leaving bedside nursing. You know, I feel like there's a reason we go into healthcare, and it's because we do want what is best for our patients. So it's really hard to settle with that feeling of I'm not doing my best, I'm not taking the best care of my patient, and I'm not taking care of them as safely as I could be. And not only that, but feeling that both at work and at home. I know that's something I struggled with, and many of the people close to me struggled with as well. So moving into the population health space, it just really opened my eyes. I mean, there is so much untapped potential that we have to creatively target patients, implement workflows, overall implement a design that can really let us as practitioners operate at the top of our license, really focus our efforts in the right areas, on the right patients, and kind of prevent that burnout that we're feeling. Romanis, as George mentioned, has a similar but also different background. I've learned so much from him in my time at HDAI, so I will turn it over to him to share a bit about that.
Thanks, Emily, and thanks, George. I just wanted to echo what George and Emily said. Thank you so much for joining us on this call. As clinical burnout is an important ongoing topic, it shows no signs of going away anytime soon. I feel every week modern healthcare is announcing yet another health system that's going on strike. So I'll start off with my brief introductions, and I'll describe some of my own experience with clinical burnout. My name is Miranda Joseph. I've been a nurse for, I wanted to say 2 decades, but I'm gonna say 18 years, and I'll preserve that 2 years to myself. My experience ranges from bedside med-surg, orthopedics, case management, post-acute, both in the IRF and home health space. And I would say in the last 8 years prior to joining HDAI, I've had the privilege of leading a great team of nurses, social workers, respiratory therapists, and nurse practitioners at 2 major health system run ACOs. My areas of focus really were in care coordination, community health, quality, and process improvement. And last but not least, for the purpose of this presentation, I am at the tail end of completing my PhD in industrial and organizational psychology, often called the work docs. And so this is important because of this particular topic. And so before I answer the question around clinical burnout, I really just wanted to cover some IO stuff. I think things that are quite relevant and meaningful for this presentation. And really what I'm trying to say here is that I wanted to touch on the 4 main workplace stressors that in some ways most of us have experienced. In the industrial organizational world, this falls under the umbrella of occupational stress, which refers to the interaction of employees and their work environment that can be difficult and emotionally draining. I'm not going to get into the interpersonal things around bullying. I'll save that for another time. But the first of the 4 main workplace stressors that I know we can all really understand and relate to is organizational constraints. Most people just want to do their work, but the environment at work is getting in their way. For example, it could be something as small as supply related. I know during COVID, masks, everything to protect yourself was just not available. And that forms a major stressor, followed by, honestly, not having enough FTEs to care for patients. So that's the first part. The second part is role ambiguity. And ultimately, that's when people work best when they understand what they're expected to accomplish or do. And so role ambiguity occurs typically when employees are uncertain of what they should be doing. There's the job description isn't cutting it for them, so to speak. The third part is role conflict. There are 2 parts to this. The first example would be an employee receiving conflicting demands from 2 superiors, and both cannot be done at once. Second, looks at conflict between the demands of work and the demands of home. I myself are super guilty of this. Oftentimes I'm reminded by my colleagues to stop working so late into the night. Our 4th workplace stressor, this is where we're really going to focus on, is workload. Often refers to the amount and difficulty of work a person is required to do. There's 2 parts to this as well. When workload is excessive, as George mentioned and Emily as well, people are easily overloaded. I know this is quite an obvious, and it does form a stressor on its own. But it's also possible for some to be underloaded, having little to do at work and leading to boredom. And I'm not a big fan of those people, and a sense of lower productivity and quality of work. And again, for the purpose of this webinar, we will focus on our solutions that attempt to address the workload that our clinicians are experiencing, and providing care to patients that need their attention and, most importantly, their focus. Less screen time and more face time. So George, if it's okay, I'm just going to jump into sharing my experience with the clinical burnout. And I'm going to answer this mainly from the front lines of being a care manager, but in population health management, and then slip in some leadership experience that I've had. But I'll again start with the front line. So as a case manager, some of you that may or may not know, typically you have a patient list of around 15 to mid 20 patients. May not sound like a lot, but it is a lot. It's plenty. And have personally gone as high as 42 in the acute setting when staffing was tight. Okay, there were countless days. I stayed past 8 p.m. for a salaried shift to end at 5. It was evident that some others were both myself and I were busy tackling on urgent matters, aka everything is a priority, and there's a little time to focus on the important things, like doing a high quality utilization review or discharge planning for a patient going home with every durable medical equipment known to man. I'm going to fast forward here, and when I actually jumped into the leadership role during the height of COVID, when perfect time to take on a leadership role, I tell you. During the height of COVID, when we were looking to discharge as many patients as we could, I remember times when our leadership called me, or rather the nursing team would call me and say that the patient's O2 concentrator was not delivered bedside, and obviously was needed, and which resulted in the patient staying overnight. There were a lot of when staffing was tight, I knew around midnight or 1 o'clock, I would be getting calls from the hospital to address these discharge barriers. And as you know, there are no vendors open at midnight. And so back to the front lines, overall, the workload was a lot, and it resulted in higher readmission rates, longer length of stays, because we discovered a discharge barrier 7 days into the admission, and it could have been addressed literally on admission within the first 24 hours. And this ultimately led to higher turnover rates. Every department was going through turnover rates, and HR was keeping tabs on that. And if you recall here, just to kind of summarize my response here, the 4 occupational stressors that I'm talking about, really, in my experience, touch on 3 of them. 1, workload, extremely overloaded. Role conflict, the demands of work and the demands of home due to staying late. And for physicians, this is oftentimes, I think, called pajama time when they're documenting in their EMR after hours. And last but not least, the organizational constraints due to human capital, but also the existence of bureaucratic inefficiencies and poorly designed processes. Because listen, we can shove as much data as we want, but if the processes you have in place are not tightened or make sense, frankly, that needs to be addressed. And so that concludes my response, George. Thank you.
No, thank you. And it's listening to both of you, it takes me back. My first role in healthcare was doing emergency department throughput consulting. And one of the things, I'm gonna date myself right now, but back in the day when we used to put up gigantic sheets of paper on the wall and write things on Post-it notes and make these huge process maps, one of the things we would focus upon is what nurses were actually doing with their time. And we'd just make lists of like, what do you do that is not related to direct patient care? And the lists were eye-popping. You know, we're changing linens, transport, just you name it, right? And we would try as hard as we could to take as much of that, what we refer to as administrative burden or non-direct patient care, off their plates as possible. And here we are, over 20 years later, and it sounds like not only is it's not just that it's the same, it's actually gotten a lot worse due to extrinsic circumstances. But I know both of you work very closely with our clients. Wondering if you could share not just so much specific examples of how they're using advanced analytics and AI in their workflows, but how they responded to it. And to your point, Romana, I'm also curious about sort of how they're using it, but also how are they incorporating it into their workflow? Because I think you raised a really important point, which is if you give me the best in class tool, but it's not crystal clear how it's supposed to fit in my day-to-day and how I'm supposed to incorporate it into my existing workflow, it might not yield the benefit that we would hope. So if you could talk about sort of some real life examples of how this is being done.
Absolutely. So we work with a lot of clients, and so the AI, first of all, I want to mention that AI adoption does not happen overnight. The validation of predictive risk requires healthy back and forth conversations with clinicians and leadership to dial in the predictions and make sure they make sense. And even just as important, integrating it into their daily workflow, like you said. one of our health system run ACO partners uses our data to really improve patient targeting and prioritization of care. And I'll explain what that means here. It's a team that is well staffed. The physician and nurse leader are excellent and super engaged and are always questioning everything we do for them, which is good, which is really quite healthy. But despite being well staffed, they are responsible for managing over 50,000 MSSP lives, in addition to other value-based arrangements. Manning that to kind of grasp that many patients is really quite tough. And so, keeping in mind their current workflows, we took their 50,000 lives and put them into specific cohorts, and these cohorts are really designed to kind of subjectively and quantitatively describe patients that fit into the advanced illness bucket. So these are patients that are at a high risk for mortality and high risk for likelihood of entering into hospice. And then for the complex care bucket, not only are they sick and have many different chronic comorbidities, they are also at a high risk for an unplanned admission, in addition to being at the 10th percentile of being at risk for mortality, followed by the rising risk and the low risk population. So 50,000 lives, way too many to manage. Who do you even begin to start with? And so this resulted in putting these folks into these specific cohorts. It resulted in a smaller sample size of patients, but still large, because depending on which cohort your patients are in, it can be quite large, especially with an ACO this big. We then took it a step further and really identified patients that were at the top 5% of their mortality and likelihood of entering hospice. We chose AIC here. And titrating further down to those who have not had an annual wellness visit. Okay, I mean, that is one intervention, one major checkpoint for patients in an ACO. And because this is a very sick population where mortality runs high, we also then looked at was there any encounters around advanced care planning? At this point, we went from 50,000 patients down to a smaller, much targeted and actionable list of patients their care team could manage. The additional filter would be based on the physician practice, on where they would engage those practice managers or those physicians. And then now you're looking at single-digit numbers, to be honest with you. It all depends on where you want to focus. And to be honest, it took about 2-3 months to actually get to that point. Okay, and this is where adoption of AI is not readily acceptable by the community, including healthcare folks. But it took us 3 months. And we continue to address any of the efficiencies that look off clinically. So it took us 3 months, but these continued conversations need to be had, because in case there's a blip in the system, our clinicians and ourselves are able to pick this up. And so, real quick, George. So for most of our partners, thankfully, this is very much so quite helpful for both Emily and I, is that these systems have a pretty good system in place already, and in terms of transitions of care, chronic care management, disease management, palliative hospice care, it's already there. There's really nothing, no new added intervention that's needed. And so our solution really is to prioritize which patients they should enroll into these programs, and continue doing that. For basically what we're telling folks is that continue doing what you're doing, but just do it for the right group of people first. And so that's a very important message, and how we see AI alleviating the workload that a lot of clinicians are having to deal with. Again, 50,000 patients, okay, that's a lot. So I guess just my last closing statement here, George, around this question is that AI adoption does take a lot of work. And ultimately, we will get closer to seeing how it can improve overall patient outcomes in all facets of healthcare. Remain skeptical. It is in our nature to do so. What makes us human, but also make a concerted effort in understanding what AI has to offer. Man, it is a lot. But apply it in such a way that makes sense at work, and most importantly, that makes sense in your own lives. Because that reigns king over anything else, really. So thank you, George.
No, thank you for that. I mean, I would argue that focus and priority are important, regardless whether that's in work or in life, in any profession, but especially when your work is literally saving lives and healing people. it's even more important. And then again, layering on staff shortage, it's not an option. It's mission critical, given this time scarcity that we're in from a staffing perspective, to have that focus and priority. I also love what you said, and I think it bears underlining about the fact that none of this is a magic trick. Like we're not Harry Potter, and it's not just flip the switch and all of a sudden everything's better. Like adaptation takes time, clinical validation takes time. Obviously, if you're changing your workflows, getting used to those new workflows and really sort of embracing them takes time. And I'm curious, Emily, and not to tweak your PTSD from your nursing days, but I'm curious, when you think back to when you're at the bedside, to what degree, if any, did you feel like you had tools that helped you hyper-focus and prioritize on the patients with the greatest unmet needs, and to surface what their specific unmet needs were? Was that a thing, or not so much?
I would have to say I was in the pediatric space to start for the majority of my time, so not so much is probably my initial answer to that. But I think when we look forward and what tools really could have impact, I mean, I could talk about this all day. I think before really diving into that question, I would touch on that the real issue here is, the need for artificial intelligence in data acquisition and analytics is really driven by the fact that these machines have become so sophisticated. They produce so much data, and it's nearly impossible for a group of human beings to really perform upon all of the insights of that data. And it's already hard to sustain now, but it's just going to keep accelerating and moving forward, and the machines will get smarter and they'll produce more and more data. And so we have to come up with a solution of how to utilize it. And I'm biased because this is the work that Romanis and I do, but I really think we are honing in on that solution, and we can't let it pass us by because we'll lose amazing opportunities. I hear about and I read about a lot of the fear that people have. I mean, I think I have some of my own skepticisms that AI could replace people, but really what I think it is it won't replace people. It's the people that know how to utilize the AI and the data that they're being given. Those people will replace the people who don't adapt or resist the change or don't learn how to utilize the data. You still need humans. We're always going to need clinical judgment. And that's really the point, is getting to that place of opening up these care providers and practitioners to get to the place where we can really do the meat of the work again. So to go back to your question, how these tools can be available to us, we know that AI really can track patient data more efficiently than humans can, more quickly than we can. So we can enable organizations to kind of connect the dots of the information in ways that it wasn't previously used, but have maybe always been there. And then we get this really kind of cohesive patient picture of their overall health. And then not only that, but to go back to what Romanis was talking about, we can find those sort of needle in the haystack patients, and we can save providers time, save the patient time, save on overall spending, and ultimately we could save a life because we are better managing their chronic diseases and we're doing it earlier. So my hope is that, I see all across the country, I would hope that we gain awareness of these tools, they're implemented at the system level, and that just becomes the baseline of care, because when done the right way, that lets patient care assistants, nurses, physicians all have more time at the bedside. I think I do have one more comment. I said I could talk about it all.
Go, please.
I think about it because I do talk to my husband about this at home, and it's what we do every single day. But I think could be really cool in the future with AI, because really, again, it's limitless, is patients having that same access to those predictive analytics and those risk scores, and really understanding that they are at risk. And once they have that knowledge, not to be corny, but knowledge is power, and then they could, make those day-to-day changes that really help them better manage their potential chronic diseases as well. So I think it impacts everybody. And at the end of the day, it's all about better patient care. And I think we have that opportunity right in front of us.
Yeah, no, I thank you. I love all of that. You know, a couple of things in particular. It's amazing to me, again, both in healthcare and outside of healthcare, how often we allow technology to outstrip our ability to use the technology thoughtfully and intelligently, right? It's like we come out with this thing or this idea or this, you know, this device, and then we say, okay, now let's back up 20 steps and figure out what makes sense here, right? And what is the right way, the ethical way, the effective way to deploy this. The other thing that both of you touched upon, and I want to make sure that this was heard clearly, is for the longest time, the state of the art in risk profiling has been 100% retrospective, right? So I would look at my claims data set and I would say, wow, George was really sick and really complex and really expensive last year. So I'm guessing he's going to be really sick and expensive and complex this year, right? And so I would hyper focus on George and try to keep his chronic illness or illnesses under control, manage costs, et cetera. Perfectly fair and reasonable. But what I heard you both say is that we're less interested in looking out the rearview mirror and more interested in looking out the windshield and saying, show me what's coming. Show me who is about to get that diabetes diagnosis, who's about to get that depression diagnosis, who doesn't already have it, and where I perhaps have a better chance of avoiding unnecessary suffering, unnecessary utilization, unnecessary costs, and alleviating some of the burden on caregivers who don't have to take care of me because we thankfully avoided a chronic condition because we saw it earlier. And I love that. I love the idea of swimming upstream and identifying things when we're actually able to do something about it and not just manage what's already a difficult case or a difficult condition. So we have a couple more poll questions. I hope everyone's still paying attention so that you're perked up and ready to answer. So Garrett, if you could take us through those, and then we'll switch to Q&A and wrap things up.
Great. Okay, next polling question. Let's see here. Is do you have interest in or familiarity with AI tools that can help with burnout? This is another police select one. Yes, no, or not applicable to my role. So we've got some answers coming in here, responses rather, and then of course we'll share the results here shortly with everyone. And these are anonymous, by the way. So no one else will see what you answer, but be good to see kind of where you stand among your colleagues. All right, I think we have most of our responses in, but I'm going to give it a few more seconds here. Give it about 10 seconds. Okay, I'm going to close it down in about 5 seconds. 5, 4, 3, 2, and 1. Close. And now let me go ahead and share the results.
Okay, interesting. Yeah, there's been this is interesting to see. There's been a substantial uptick in, as I mentioned very early on in our conversation today, in the number of organizations, both traditional healthcare organizations and new entrants, investing in AI and pursuing AI. Google, Amazon, others are, Apple, Microsoft, all of them are thinking about things, doing things, creating partnerships. So I would imagine this poll would look quite different even in a few months from now, but this is already pretty high numbers. So that's terrific to see.
Okay.
And then the last polling question, I think we have one more.
Yeah, okay, we'll go right into that one.
Yeah.
Let's see here.
Yes.
All right. Last one is, are you ready to adopt an AI solution? Again, please select 1. We are ready now. We're getting there. We should be ready in the next 6 to 12 months. We won't be ready for a few years, or we likely will never adopt an AI solution or not applicable. So just select 1. And we've still got responses coming in. And again, this will just kind of give you an idea of where you stand among your colleagues in terms of readiness. So, okay, I think most of the responses have come in. So we're going to give it about another 5 seconds. 5, 4, 3, 2, and 1. And yeah, this should be pretty straightforward. Okay, so I'm going to close this out and then show you the results.
Wow. Okay. So about half are I'd say near term ready, which is interesting to see, and definitely again a high number. I don't think it would have been nearly this high even 6 months ago. So this is encouraging. One thing I do want to do, Gary, before I pass to you for Q&A, and actually I'm going to use this poll question as a springboard for this. If I could just say a few closing words before we open it up to question and answer. Readiness, I would argue, is the most important factor in considering an AI solution. Otherwise stated, if we were to bring to you, or any partner were to bring to you, sort of the gold standard in clinical generative AI, but your organization wasn't prepared to embrace it, to adapt it, to embed it in their workflow, and to make meaning of it, that would be, I think, I don't want to say tragedy, but it would be unfortunate, because you're investing in something that literally isn't going to make a difference to your providers or to your patients. And I personally have seen way too many examples of organizations running towards solutions that were compelling, that were exciting, without giving sufficient thought to who's this going to help, how's it going to help them, and those kinds of very pragmatic, tactical questions that I would argue are as important as the sort of independent value of the solution on its own. And so I would encourage all of us, if we're going in this direction, the half of you who are getting there, or there now, are getting there fairly quickly, to think about, and frankly, to talk to your clinicians, talk to your clinical leadership, talk to your frontline nursing staff, your care managers. What would help you? Would this help you? How would it help you? Because ultimately, that's going to, if the answer is yes, it's going to drive adoption. It's going to make for a better investment on your part, and ultimately, where this all matters, the end game, it's going to make a bigger difference for your patients and for your providers, and hopefully, and this is the hope, reduce some of the burnout, reduce the stress, and increase their love for their jobs, and help them find the joy in what they do again, if they don't already have it. So I'll shut up now, and Garrett, if you want to take us through the Q&A, that'd be great.
All right, sounds good. I'm going to hide this one. And yeah, let's go into Q&A, because we do have some audience questions. If you do have a question, by the way, go ahead and ask it now. And you can do that. I'll come back on camera as well so you can see me. And you can do that using your little module that you have as an attendee. There's a place actually for questions. So go ahead and drop your question in there. We're going to get to as many as we can. If we don't get to yours, don't worry. Someone will reach out via email to answer your question. But in no particular order, let's go ahead and dive in. The first question is this. How do you work with existing EHR or care management system, like what's available in Epic?
I'll start this one if that's okay. So we are capable of embedding our predictions, our models, in not just Epic, but any EHR, Athena, Cerner, et cetera, and also within any care management platform. So in other words, your user, whether it's a care manager or nurse, physician, whatever, all the above, would be able to see the predictions in their platform of choice. And if we have an integration with their EHR, in other words, if we're getting real-time clinical data from them, which we have the capability to do, they would be able to see those predictions update real time, literally while the patient's still with them. I also want to add to that, because I think it bears mentioning that some of the EHR companies, maybe all of them, I don't follow all of them very, very closely, but I know Epic, for example, is pursuing development of its own models. I think they might even have a handful today. And so back to what I was saying earlier, I think it's important to take a beat to ask yourself, what are they actually giving me, and how does it compare to what either HDAI or another vendor can give me? Because the last thing you want to do is give your providers two tools that answer the same exact question and not give them any guidance as to which one is the right tool for this particular job, and it happens all the time. Emily or Manis, anything you'd want to add to that?
Yeah, I've been closely involved with the folks that are using Epic, and so just very quickly, George, it's one thing to one of the things that we're doing with Epic is that we're helping case managers and nurses identify which patients they should prioritize, and ultimately, to be honest with you, sure, great, thanks for telling me who I should prioritize, but let's be honest, a good clinician, if given the time and place to focus, they can absolutely be effective in completing their task. But if there's an increase in workload, and I mentioned this earlier, it gets a little bit more difficult, right? To important on the things, to focus on things that are important. And ultimately, again, I keep saying this here, direct clinical face time is reduced when this happens. And second, but not least, George, not only are we identifying patients, what these concerns are, and we're also surfacing the drivers of these predicted risks, like readmissions or mortality. And some of these drivers may be obvious. Again, a good clinician will be, yeah, duh, I know this, right? But again, when you scale this out, some may not be anymore, right? Because you're kind of lost in doing other things. And so in the busyness of day-to-day work, this is an attempt for a lot of AI companies, including ourselves, to really enhance a clinician's intuition and improve decision-making. That could lead to better patient outcomes. Yes, AI right now is handling a lot of administrative tasks. This is great, but I'm looking at it in a way that would sharpen a clinician's thought, mind, decision-making, everything that could be driven and solely focused on improving that patient that's sitting right in front of you. So just wanted to add that, George. We go a little bit telling people to focus on them.
That's a really important point, and it reminds me of I'm not going to name names because that would be impolite, but in the earlier days of risk prediction using data, and I was at one of these firms that did that work. We were pretty good at saying, Emily's going to be in the hospital in the next 6 months if we don't do something, but we were really bad at identifying what the thing was that they needed to do to keep her out of the hospital, not terribly useful if Emily's polychronic and I'm sitting there trying to sort out what is the thing I need to focus on to keep her healthy. And to your point, I think it's critical that you not only say this person's high risk, but what's driving the risk. And as we all know, with polychronic complex patients, that's a moving target. It's different now from what it's going to be in 4 or 6 weeks. Yeah. Garrett, any other questions?
Yes, we do have a few more. So next question is, do you have any social determinants of health incorporated into your predictive models?
Wow. Okay, so honest moment here, yes. I should say, let me back up. We are actively working on embedding those data into our predictions. One of the challenges we're running into is the data itself, because may go without saying, but our models are trained on claims on clinical data, whether that clinical data is structured or whether we mine the unstructured nodes using generative AI to surface those diagnosis and treatment codes and information. The SDOH data today isn't as, I'll say, thorough and complete and normalized as we need it to be. Now, in some cases it is, in other cases it's not, but it's still kind of evolving. Sort of what data elements do we need? There's no like standardized set of SDOH data elements that are available to us in a form that is, I would say, efficient or convenient for us to incorporate. Having said that, we are doing that work and working really hard to do it because, as you all know, and yet another topic that rightfully is getting a lot of press coverage is the things that land me in the ED or in the hospital are things that happen in the community. lack of transportation, lack of affordability for medications, lack of food, right? All of the above. And so if we are serious about value-based care, and if we're serious about defending the perimeter of the acute care setting against things that don't need to be there, we need to get much more serious about SDOH, and we're absolutely running toward that, and working with organizations to make that data more usable for the purpose of training our predictive models. Yeah, but today, it's a work in progress, just to be completely honest. Yeah. Emily, Romanis, anything you want to add, or?
Covered it pretty well, George. Yeah, thanks.
But stay tuned, Garrett. It's coming.
Okay, yeah, well, stay tuned.
The Epic integration does help, because there are teams that do a social determinants of health screening. So that information, quite valuable, can absolutely be ingested as well, future state. But it's something
that's a great point. Yeah, if it's there, we use it, but the challenge is oftentimes it's not collected, and that's where there's literally nothing we can do to incorporate those data if they're not there for us. So
awesome. Well, we do have some more questions, so keep plugging along here with the time that we have. Again, if you have a question, go ahead and ask it now. Do you see health systems really investing in AI given all the financial headwinds they're facing currently?
Ooh. Emily or Mattis, do you want to kick us off here?
Yeah, I can kick it off. Romanis, I want to make sure you get to talk as well, but I mean, I think
it's all you, Emily.
Okay, leaning on what we talked about earlier, I think it's really just inevitable. It's just a matter of how health systems end up adapting and when. It's not so much if they will. I think the way we're going, like I said, there's ample amounts of data. It's really honing in and being able to dig deeper and get into those targeted patient populations. And I think as the front line or the staff start to feel the effects of what AI can do and the impact it can have on the patients, I think it really will just be an eventual, inevitable happening that health systems get on board.
Yeah, I absolutely agree with that. In fact, the poll kind of indicates as much. My concern, I guess, is I would say on the one hand, I think sooner than later, but soon everyone's going to be either there or moving there, meaning making an investment in AI. My concern is that it's getting awfully noisy out there. There are a lot of folks talking about AI. It's becoming increasingly difficult to distinguish among some of the different solutions. And my concern is that, as kind of going back to what I said earlier, is that investments are made prior to sort of pausing to really consider at a tactical level, at a frontline user level, how's this going to matter? How's this going to make a difference? And of course, once you make the investment in A, you forfeited the opportunity to make the investment in B. Yeah. And so I would, again, just not to beat a dead horse, but I would encourage everyone who's thinking about it to talk with the folks who are going to actually use these tools and use these insights to change the way in which they interact with their patients, and ask them, would this help? How would this help? And make your decision accordingly. So, yeah.
Very cool. All right, guys. Well, unfortunately, we are kind of running up on time here. We did have some additional questions that came in. But don't worry, again, we're going to make sure that you get an answer to that. Someone will reach out to you through email and answer your question. So again, if you have a question, go ahead and ask it now, and someone will reach out to you. But as we conclude, first of all, I want to thank our speakers. You guys did a fantastic job. This is such a rich subject. There's a lot there, and you guys did a really good job of bringing in some good practicals, some applications, and some real world experience there. So thank you for that. As we conclude, I'd like to encourage you all to stop by vbcexhibithall.com. And this is where you can actually visit the Health Data Analytics Institute virtual exhibit booth that they have there. And this is a really cool tool that you can explore a lot of their resources, a lot of their services, kind of read up on them, what they do. There's a lot of great information there. And so I definitely encourage you to do that. And in the slides, there'll be a link that you can go and visit. And then finally, actually, real quick, before we wrap up, I wanted to make a little announcement, a little plug for these guys. They will be at the health conference, the HLTH conference here in Vegas, on the 8th through the 11th of October. So make sure to go visit them. Or if you wanted to set up a meeting or whatever with one of them live while you're in town, please reach out to them directly or to me. I'm happy to introduce you as well, but definitely go see them there. And then finally, if you would like to reach out to the HDAI team or to the speakers today, their information is here on this slide, and so you can contact them directly, or you can contact, it says Holly down there, and she will get you to the right folks. But it's a great organization, been really a privilege to work with them, so I think you're in good hands with them if you are in need of their services. But thank you all again so much for joining us today. Again, we're going to send you a link here shortly to the recording and to where you can download the slides. But hope you join us again for a future webinar. Thanks so much and have a wonderful afternoon. Bye-bye.
Thank you, everyone.
Bye.
Bye.